Okay, so class, let me welcome you again to this ENT class. So, continuing our lectures, your fourth year lectures. So we completed a year, and now we are talking about nose. And even on nose, we have completed a few topics. So today we are going to talk about epistaxis. Okay, so epistaxis is a very important topic. Okay, it is very important for so many reasons. One reason is that it is a very common ENT emergency. There are few ENT emergencies. Okay, and this is one of them. And again, this is important for you because as an MBBS students, you need to be able to manage a case of epistaxis very well. Okay. So this case, you may be posted in a central hospital or in a periphery. So wherever you're working, when a case of epistaxis comes to you, you should be able to stop it before you ask help from the senior doctors, right? So when talking about epistaxis, we need to know something about the basics of the epistaxis, okay? But the most important thing is the management of epistaxis. You know the theory about epistaxis, but if you're not able to manage it when you get a case, then that becomes useless, okay? But still, understanding anatomy will help us to better manage the case, okay? So how do you define epistaxis? So this is a very common question for you, okay? In the exams or anywhere else, in the rounds, you will ask, define epistaxis. So it is bleeding from within the nose. So you can see here, the size of the font is different, okay? This within I have enlarged it. Why? Because this probably is one of the most important preposition or word in this whole phrase, okay? Suppose somebody has okay, all of this is nose. If you say epistaxis in bleeding from nose, so that may not be correct, okay? If you got a cut injury here, so the person is bleeding from nose. But if one bleeds from here, this is not epistaxis. It should be from inside the nasal cavity, within the nasal cavity. Okay, this word epistaxis, it comes from the Greek word epistazo, where epi means above and stazo means to drip from nostril. So it is the commonest otolaryngologic emergency, and it affects 60% of the population in their lifetime, while only 6% of them require medical attention. Okay, so this is a very important point. So many people they get affected, but so few people they require medical attention. Okay. Now, because in epistaxis we are talking about bleeding, so we need to know. So what are the systems or what are the arteries that are involved or what are the veins that may be involved, okay? So that will help you to better understand the management of the disease, all right? So there are two systems, okay? So the nasal cavity has two important parts, the lateral wall and the medial wall. The medial wall is the septum and the lateral wall has turbinates and many other structures. Similarly, there is ceiling, roof, and there is floor. So we are not most concerned about the roof and floor, but most of the bleeding they occur from the lateral wall or the medial wall, which is the septum. So in both the cases, there is internal catheter system and the external catheter system that is supplying these areas. Now, the septum, okay? So, as mentioned in the last slide, okay? The blood supply is from both the systems, the external catheter system and, okay, please do not draw on the slide, right? The internal catheter system has two branches in the nasal cavity, anterior ethmoidal artery and the posterior ethmoidal artery, okay? And you do not get to say, and they do not come directly, they are not the direct branches of internal catheter system, okay? So, internal catheter artery, it divides into ophthalmic artery, okay? Branches, and from ophthalmic artery you get the anterior ethmoidal artery and posterior ethmoidal artery, okay? Similarly, from external catheter system there are these two main branches, okay? Maxillary artery and the facial artery. From maxillary artery you get the sphenopalatine artery, and from the maxillary from the same maxillary artery there is greater palatine artery, and similarly superior labial branch from the facial artery. Right? All these words and terms, they may sound similar, but this one particular slide is a very important question, and this almost always asked in various exams. Okay, right? So internal carotid artery branches into ophthalmic artery, which branches into anterior and posterior, and the external carotid system has these branches. Now, lateral nasal wall, right? So in case of internal carotid system, it is the same, but in case of external carotid system, there is a little different. Okay, posterior lateral nasal branches from sphenopalatine artery, greater palatine artery from maxillary artery, and nasal branch of inferior superior dental artery from infraorbital branch of maxillary artery, and branches of facial artery to nasal vestibule. Okay, lateral wall of the nose is also important, but we are more concerned about the medial wall or the septum. So try to focus on this. Okay, so look here. Here we have internal carotid artery. So it branches into ophthalmic artery. From the ophthalmic artery, there is anterior ethmoidal artery and the posterior ethmoidal artery. So you can see it coming from here on the septum. And similarly, the external carotid artery comes from here and it gives 2 branches. Okay, it has 8 branches. Here in epistaxis, we are dealing with only 2 branches. So the major branch is maxillary artery. So it again divides into 2, sphenopalatine artery and greater palatine artery. Okay, and the facial artery, it divides into superior labial artery, and again it has the septal branches which go up to here. So you can see here there is one term that I have mentioned here, litus area. Okay, so this litus area is a very important area in the whole of epistaxis. This is almost always an out question. Okay, you may ask what is litus area and what are the arteries that supply the litus area. So here you can see in the previous slide about the septum, I have mentioned here a total of 5 arteries, right? 2 from the internal carotid system and 3 from the external carotid system. So look here. What are the arteries that come relatively up to this area? Okay, the sphenopalatine artery, its branches are reaching up here, and the septal branches from the superior labial artery of the facial artery, they are coming here, and similarly the greater palatine artery and the anterior ethmoidal artery. And what you see here, the posterior ethmoidal artery, it has just finished here, right? Its branches do not go up to here. So it is a very common question where the students they are asked, okay, among 4 of these, which of the artery is not a part of litus area? Okay, the options will be anterior ethmoidal artery, posterior ethmoidal artery, greater palatine artery, or sphenopalatine artery. So you need to choose posterior ethmoidal artery, or you can have different options. So posterior ethmoidal artery is not involved in litus area. Okay, this is a very common question. And always remember these 4 arteries that supply the litus area. These are almost always asked. Now, because we are reading about bleeding and the branches of the external carotid arteries, so we need to recapitulate. Okay, how these or from where these blood vessels are coming. So here, let us go here to the heart. Okay, the heart has hearts of aorta, and then there are 3 major trunks. Okay, the brachiocephalic trunk, and then we have left subclavian and left common carotid, right? And this brachiocephalic trunk, it divides into 2, right subclavian and right common carotid. Okay, so this part, the brachiocephalic trunk, so this is here, right? And now look here, so it is divided into right subclavian and right common carotid. Okay, so we are not going to deal about this part, we are going to only deal about this part. And here the common carotid artery divides into 2 parts. One is internal carotid artery and another is external carotid artery. Okay, the internal carotid artery, it goes towards the brain, and the external carotid artery, it gives many branches which are very important for the ENT surgeon. As an ENT surgeon or even as an ENT student, you need to know these arteries well. The External carotid artery, it has 8 branches, right? 3 anterior, 3 posterior, and 2 terminal branches. Okay, the first branch is superior thyroid artery. The second branch is ascending pharyngeal artery. The third is lingual, then the facial, then the occipital, postauricular, and the terminal branches are superficial temporal artery and maxillary artery. So in epistaxis, we are dealing with maxillary artery, the branches of facial artery, and the branches from here. Okay, the internal carotid artery branches into ophthalmic artery, and then the anterior and posterior ethmoidal arteries. Okay, this is a similar image. Okay, so you can see here, this is how the external carotid artery is going here, and see the 8 branches. So even as MBBS students, so this is almost always asked to pieces of ENT ENT. But even as MBBS, you may be asked what are the different branches of external carotid artery. Okay, so 3 anterior, 3 posterior, and 2 terminal, altogether 8 branches. And in subsequent classes, in different ENT classes, we'll be dealing with other arteries as well. Now this slide, it is somewhat similar from the image that I showed you in the last slide, but in a different orientation. Okay, so look here. So this is the common carotid artery. It goes up to here. Then the internal carotid artery and the external carotid artery, right? And look here again, the external carotid artery. So it has the different branches. This is the internal and the external, and this is the common carotid artery, right? This is the arch of aorta. Okay, so this litmus area. Okay, so what is litmus area? Or the question can be define litmus area. What are the arteries that form litmus area? Okay, there can be so many questions based on litmus area. So it was identified by James Little in as early as 1879. Okay, so that was nearly 1.5 century ago, 150 years ago. So it is an arterial plexus on the anterior septum, and this is a frequent site of bleeding. So this same area was described a year later by Kisselbach's plexus. So this is also known as Kisselbach plexus. Okay, and it is exposed to drying effects of inspiratory current and fingernail trauma. So where is litmus area present? It is present in the anterior inferior part of the nasal septum. Anterior and inferior part of the nasal septum. Okay, and you can see the same thing here. Okay, this whole is the nasal septum. This is the quadrilateral cartilage and quadrilateral ethmoid and the bomber bone here. And this is the vestibule, the opening here. And this is the litmus area in the anterior inferior part of the nasal septum. Now it is formed by the 4 arteries. We have already talked about these 4 arteries: anterior ethmoidal artery, septal branch of superior labial artery, septal branch of sphenopalatine artery, and the greater palatine artery. So anterior ethmoidal artery is a branch of ophthalmic artery coming from the internal carotid artery, and superior labial artery is the branch of facial artery, and these 2 are the branches of maxillary artery. Now, litmus area is not only the area that is involved in epistaxis. Bleeding can also occur from retropulmonary vein. So it runs vertically downwards, just 2 mm behind the columella. So this is the columella, just behind it there is retropulmonary vein. It crosses the floor and joins the venous plexus on the lateral nasal wall. This is a common site of bleeding in young people. Just like the Kisselbach plexus, there is one Woodruff plexus. It is a plexus of vein situated inferior to the posterior end of the inferior turbinate. Site of posterior epistaxis in adults. Okay, so all of these are the important points. Okay, there are a few points, but all of these are important. So you need to know where it is located. This is also frequently asked question: where is Woodruff plexus located? So it is situated inferior to the posterior end of the inferior turbinate. Okay. Okay. The inferior turbidity is around here. Okay. And the posterior end of the inferior turbidity here, and it is situated just inferior to that area. So whenever we do the diagnostic nasal endoscopy, we can easily see the bleeding if it is occurring from there. Okay. So what are the causes of epistaxis? So idiopathic 55%, there can be local causes and there can be general causes. So this one point is very important. Idiopathic, it means we do not know why it occurs, and we also do not know why it stops. Okay, in the first slide, I mentioned that epistaxis is very common, but only 6% of the patient they require admission. So because of the idiopathic nature, okay, आफै सुरु हुन्छ आफै बन्द हुन्छ किन हुन्छ कसैलाई थाहा छैन है, but that is idiopathic. But the patients, especially when the patients are the child and their parents, they are very anxious and they need an explanation for the bleeding, and we need to explain them. So you can call it idiopathic only when you have ruled out local and general causes. Though idiopathic is very common, more common than the local causes and the general causes, but before you label it as idiopathic, make sure you have ruled out any local cause for epistaxis as well as general causes for epistaxis. Now, what are the local causes? So any condition that is occurring in the nasal cavity that is causing the bleeding. It can be congenital, like in hereditary telangiectasia. It can be trauma, okay, very commonly due to trauma. So trauma can be any accident, any fall, any injury to the face, okay, or it can be even due to something as minuscule as nose picking. Okay, nose picking is very common in our part of the world. The children, they pick the nose, the adults pick the nose, everybody picks the nose, okay. Similarly, the trauma can be because of nasal surgery or even due to foreign body. Similarly, infection can result in epistaxis, okay, like in vestibulitis, sinusitis, atrophic rhinitis. Okay, we'll talk about atrophic rhinitis later on. Rhinisporidiosis and rhinisporoma. Okay, similarly, in neoplasms like angiofibroma, hemangioma, inverted papilloma, and malignancy. And in the last class, we talked about deviate nasal spur, okay, because the mucosa is stressed and it is exposed to the currents of the air. So there is more tendency, increased tendency for bleeding from the spur. Now the general causes, okay, hypertension, yes, okay, bleeding disorders, hemophilia, thrombocytopenia, leukemia, okay, and there are several drugs like aspirin and anticoagulants. If the patient is taking this drug, then they are predisposed to epistaxis. Similarly, there can be physiological conditions like cold and dry climate, okay, high altitude, vicarious menstruation, violent exertion, and barotrauma. Similarly, liver failure and erythematous fevers. Also, these physiological conditions are very important as well, right? So a human body, it can, the perfect conditions, for a human body to survive hasn't got a very big range. A human body cannot survive in very, very hot climate or a very, very cold climate. So whenever it is cold and dry, so the friction will be more, and that way there are more chances of bleeding. So dryness may cause the crusting. Similarly, high altitude due to the decreased air pressure and barotrauma in the scuba drivers or in the space. Okay, there can be chances of bleeding. What are the common causes of epistaxis based on the age group? Okay, in children, nose picking, foreign body, exanthematous fever. In adolescents, nasopharyngeal fibroma, trauma, sinusitis. In adults, sinusitis and trauma. In elderly, hypertension and malignancy. So I have divided it into this so as to make you understand that whenever a patient comes in the ER or in the OPD, and so based on his age, you suspect these to be the causes of epistaxis. You don't have to suspect malignancy, no. young child. Now, commonest site for epistaxis. Okay. So why this area is important? Because it is the commonest site and it is involved in 80 to 90% of the cases of bleeding. Okay, it is the Kisselbach's arterial plexus at the anterior inferior part of the septal cartilage and mostly common in children. So Ursus plexus is also another common site, but it is not as common as this area. So it is near the posterior end of the inferior turbinate, common in elderly, hypertensive, and retropulmonary vein is common in adults. So look here. So this is the latest area that we are talking about. You do not get such a marking on the nasal septum, but this is just to make you understand, right? So this is the anterior ethmoidal artery coming from here, and the greater palatal artery branches, and the spinopalatal artery, and the superior labial artery. And see here, the posterior ethmoidal artery, it just ends here. So it is not supplying the latest area. Okay, so look here. This is another common site. This is the Ursus plexus. Right? This is sinus, and this is the inferior turbinate, the middle turbinate, superior turbinate, and just behind the posterior end of the inferior turbinate, okay, inferior to that, you get the Ursus plexus. Now, what are the differences between anterior epistaxis and posterior epistaxis? This is also a very important question and a favorite question for many ENT surgeons to be asked in MBBS terminal examinations, right? So this point is, or this chart is important because the management becomes different. When you diagnose the case in anterior epistaxis, you manage the case in one way, but when you diagnose the case as posterior epistaxis, the management is completely different. Right? So your anterior epistaxis management maneuvers is not going to control posterior epistaxis. So let us know the differences. You can write it down if you like, or you can just take a snap or a screenshot, right? So the incidence is, it is more common, posterior epistaxis is very common. Okay, so that is a good point because it is easy, it is more easy, or it is easier to manage anterior epistaxis than posterior epistaxis. Localization, yes, it is very easy to localize the bleeding area or the bleeding artery, but in posterior epistaxis it is very difficult. The common site is this area, and here it is Ursus plexus, and it is mainly common in people younger than 18 years, but it is common in patients older than 40 years. The common cause is trauma, and here the common cause is hypertension. The treatment is by anterior nasal packing, and in the posterior epistaxis, the treatment is by posterior nasal packing. Okay, so this is another point to differentiate between anterior nasal bleeding and posterior bleeding, right? So here you can see, I probably have seen this before too, okay? This is the skull, and this is devoid of nerves, arteries, veins, muscles, soft tissues, and everything. So this opening is called the pyriform aperture. So any bleeding occurring anterior to the pyriform aperture is anterior bleeding, and any bleeding occurring posterior to the pyriform aperture is the posterior bleeding, okay? But to localize the bleeding, you are not going to deglove the face, okay? So mostly the clinical definition is, okay, anything, if the blood is dripping from the anterior nose, it is mostly anterior bleeding. But it is, if it is coming out from the mouth, then it is posterior bleeding. But that is not always the case. There is so much of overlap. Okay, suppose a patient has a bleeding from this area, but he is in supine position. The blood will come out from the nose as well as it will go inside into the nasopharynx, into the mouth, and the patient will spit out the blood. But the pathology is in the latest area. It is not in the Ursus plexus. So it should, though the bleeding is coming from the mouth or the posterior part of the nose through the nasopharynx, the management is only anterior nasal packing, right? Similarly, those who have posterior epistaxis, they may be bleeding from the mouth as well as from the nose, because wherever the blood finds a root or a cavity or a gap, it will flow from there. Now, this slide is also important, right? Because more than the theory or the definition of epistaxis, we are concerned about the management, right? A patient is there in the ER or in the OPD, you stop the bleeding, okay, your work is done. But you need to know how to evaluate, okay? So you need to know the mode of onset. Is it spontaneous or finger neck trauma? So if it is finger, all of these points will help you in the management of the condition. Okay, if it is a finger neck trauma, so your finger is not going to go up to the posterior part, right? So it is going to get limited to the litus area or the anterior parts. So if it is due to finger neck trauma, so you can pinch the nose and you can just control it, as simple as that. Similarly, the duration and frequency of bleeding, that is also important. Venous bleeding, okay, it can be prolonged. Amount of blood loss, okay, your management. So if there's only spotting and like it has stopped, so you don't have to do anything. But if the bleeding is continuous, the person is bleeding frequently and continuously, so you may need to look for some local or general causes. Similarly, what side of the nose it is bleeding, okay, whether bleeding is anterior or posterior, okay, any known bleeding tendency in the patient or the family. Similarly, history of known medical ailment like hypertension, leukemia, mitral valve disease, cirrhosis and nephritis, and history of drug intake, analgesic or anticoagulant. So basically, we are trying to look out for the cause of epistaxis, and meanwhile looking for the cause of epistaxis, we are also trying to manage the case. Now, general treatment. Okay. So what do we do when a patient comes in the ER? Okay, so there is one general protocol, and then there is another protocol, a personal protocol that you follow. So the general protocol is, if the person is having active bleeding, he comes in the ER, what you need to do is, so you resuscitate the patient. Okay, any patient that comes in the ER, do the ABC or CAB or whatever it is said, right? So the first thing that you need to do is, you need to get, if the patient is okay actively bleeding, so get large bore cannula in both limbs, preferably of 16 size, right? But 16 size is not very frequently found. So you can just use 18 gauge needles in the both limbs and get the IV access and do the blood transfusion or the fluids. So epistaxis, very few patients they get admitted for epistaxis, and another thing is it is a very rare for the patient to die because of the epistaxis, but still they die. Sometimes it can become fatal, and losing a patient to something is as simple as epistaxis. It is really embarrassing, right? So get IV fluids, get IV access, and then you record the pulse and the blood pressure, and similarly give the adequate sedation. And if the patient is having hypertension, give amlodipine or nifedipine. So what in ER, what you need to do is the investigation, the management, the diagnosis, and the treatment. All of them run concurrently. Okay, so you don't waste 10 minutes taking the history and trying to find out the cause. So while you're taking the history, you also make IV access, give blood transfusion, or IV fluids, or and at the same time try to stop the bleeding. So what are the investigations that you sent for hemoglobin, paxil volume, blood group, and cross matching? Because you may need to transfuse. Similar, the bleeding time, clotting time, and activated partial thromboplastin time, prothrombin time, platelet count. Okay, so these are the investigations that you send as soon as you have made the IV access. Similarly, diagnostic nasal endoscopy and CT scan of the paranasal sinuses to find out the cause. Okay, this is what we understand by diagnostic nasal endoscopy. This is one of the very common ENT examination or a basic ENT examination these days, because a nose is a dark cavity and you cannot see the inside of the nose. And this one examination will help you to see all the parts of the nose and to localize the bleeding. Now, okay, you need to read or understand this algorithm. Okay, the patient comes, so do the resuscitation. Okay, so initial examination. So if the vessel is not located, and if the vessel is located, so if you can locate the vessel, you do the direct therapy, like bipolar cautery. Suppose it is bleeding from the lens area, take the patient to the OR and just cauterize the area. Okay, by bipolar cautery, and the bleeding will be stopped and send him back to home. Okay, you don't have to do anything. But if the bleeding is not localized, then you need to put the endoscope inside and try to look for the bleeding artery. And if you can see the bleeding artery using endoscope, then do the electrical cautery and cauterize it, stop the bleeding, and send the patient back home. Okay, bipolar cautery. Okay, there are two types of cauteries. Okay, unipolar and bipolar. So we are not going to talk about. Okay, I'll tell you basic. Okay, I won't tell you what is unipolar and bipolar. So in the operation theater, we use unipolar. When we are cutting the deeper structures, we use the unipolar cautery to cut the different structures, right? So bipolar is like a forceps, right? So chimchi just right? And it is connected to a machine called cautery machine. And if there is any small artery bleeding or the venous bleeding, we just put it here and the bleeding will be stopped by the electric current. It will be all charred also, and burn and then it will the bleeding will stop. Right? So that is bipolar cautery. Okay, not the bipolar that you read in psychiatry. Right? Right? So it is as simple as that. Or even when we do different surgeries, and when we open the neck or the other parts, so when we see a bleeder, we just cauterize it. Bipolar, no, that's what we used to do is, so it is a bleeding artery, suppose, and we used to ligate it. Suture material ligate it, but it takes time, right? And the surgery becomes very prolonged. And using the bipolar, what you can suppose, if an artery, if for the bigger arteries or for the bigger vessel, we always do the ligation. But for small arteries or small vessels, where we can do bipolar, so bipolar will help to save the time. Or to ligate maybe 50 seconds, 55 seconds, but using the bipolar, you can do it in just 5 seconds or 4 seconds, right? So it saves a lot of time. And when you are operating, you need to use bipolar for more than 100 times, right? So it is going to save a lot of time. Right? Endoscope value artery pata we could not find the vessel. So in such cases, we do the indirect therapy. Once we tag the nasal cavity, or packing the artery could be anywhere. So all of the arteries, they get compressed and the bleeding is stopped. So bleeding control. Okay, packs are kept for at least 48 hours, and it can be kept for as long as 72 hours. Right? But even after intranasal packing, if this is continued bleeding, then you need to suspect posterior bleeding, and then you need to do posternasal packing. And then there are other surgeries like CHESPA, ligation, right? And other surgeries where we ligate where we find out the bleeding artery and ligate it. And similarly, if the bleeding is continuous, then we need to do angiography and embolization. So in epistaxis, what is the management? Okay, that means the nostrils, Hippocratic technique, and ice pack, to constrict the nasal vessel. So if the bleeding continues, what you do is you insert the cotton platelets in 1:1000 adrenaline in the nasal cavity. So adrenaline acts as a vasoconstrictor, right? So even after that the bleeding continues, then we cauterize using silver nitrate or trichloroacetic acid or electric cautery when the bleeder is localized. Right? So I'm going to explain you these things in my own words. Right? So the patient there, you have done all the emergency management, you have the basic IV access and everything. if there is active bleeding, right? Sometimes you get a lot of patients in the OPD who gives you the history of bleeding 2 days ago or 2 weeks ago. So you do not need to do these things in the people who do not have active bleeding, only if there is active bleeding, right? Hemostatically stable, the patient there. So what you do is you try to just suction out the blood from the nasal cavity. You just suction it out, and then using the light and everything, you try to look at the bleeder, right? But if you cannot see that, right, then what you do is this first aid, right, pinch the nostrils, and we can do it at the home. And when the patient is has present in the hospital, you do not do this thing, the Hippocratic technique, because this is the first aid and this has already been done, right? So what you do is you pack the nasal cavity with adrenaline and you wait for some time, right? So in many cases, this will stop the bleeding. Because of the vasoconstriction, the blood vessels will not bleed. But if it is bleeding, then you do the suction clearance and you try to find out the bleeder, okay? And if you are able to do that, then in the ENT OPD and sometimes in emergency, we get these substances like silver nitrate, trichloric acid, and apart from this, we have also chromic acid. So what we do is we dip a cotton ball with this, a small cotton ball, and put it over the bleeding artery, and we keep it there for a while, and this thing will burn, it will cauterize, and that will stop the bleeding, okay? Similarly, this is a better method. You just pinch the artery and keep the electric cauterifer there, and the bleeding will stop. But if you do not have all these instruments, or you don't have these chemicals in the hospital setup where you're working, so what you can do is do the intranasal packing. But intranasal packing is should be done very properly. So if it is not proper, then the bleeding won't stop. So in my experiences, we have seen many cases which are referred from the periphery, and they just have some weak of cotton or some small is inside the nasal cavity. Just alikati packing garyo. So we're talking about the management, and we have already done this slide, right? So यतिको नामको लागि मात्र हैन, just packing गर्ने हैन कि we see so many cases, right? So it should be proper, and proper intranasal packing is not a difficult task, and you should be able to do it in the center where you're working. So this is general treatment, pinching the nose or the Hippocratic technique, right? This is the first aid. We do not do it here in the hospital setup. Okay, so you give the kidney trace so that the patient, like whatever blood is coming from the mouth, the patient spreads out the blood here, and if anything is coming from the nose, it will drip there. Trotter's method, right? The elderly patient is sitting position, leaning forward, mouth is open, allowing bleeding to continue till hypotension develops. Now, in the hospital setup, these are the methods that we need to be well aware of, right? Adrenaline soaked closet, right? So this is the head lamp, okay? So because nose is the dark cavity, so you can see inside the nose, and this is a speculum, okay? So using the speculum, you open the nose wide, and this is a cotton ball, and it is soaked in adrenaline, and just you put inside the nose, pack the nose, and because of the vasoconstriction action, the bleeding will hopefully stop, but not always. Right? I can look here. This is a tournament that is bleeding from here. You can see the bleeding, and our image is very clear because of the flash. It is shiny bright. So what we do here in such cases, we take a small cotton ball, not as big as that, very small, just like the Q-tips or ear of that size, not that thing, but of that size. Right? We dip it in the chromic acid or silver nitrate or trichloric acid, and just we put it here and we cauterize it area, and the bleeding will stop. This is a very good and very simple method. Now, intranasal packing. You need to know how to do intranasal packing, okay? And you need to know all the steps properly. So intranasal packing for at least 48 to 72 hours, and the patients should be given antibiotics. Why? Because anything in the nose may result in infection and the patient can go in sepsis. So there are different methods, right? So you can use liquid paraffin and antibiotic cream gauze, Vaseline gauze, bismuth iodine paraffin paste gauze, Merosil tampon, and Simpson's balloon. Right? So in the emergency, right, what you can do is you can take the ribbon gauze. Okay, ribbon gauze is found in all the emergencies everywhere, right? So you take the ribbon gauze and you take some antibiotic cream, right? Using the mupirocin or fusidic acid or anything, right? And you lubricate, lubricate that well. And you lubricate that ribbon gauze well, right? Similarly, you can also use the Vaseline gauze. And so make sure that the lubrication is proper. So even the antibiotic cream will act as a lubricant. And if that's not enough, then you can use liquid paraffin. Right? You can wax and liquid wax. You bottle up also, it is found in all the medical shops. Right? So if you write liquid paraffin, and then they will send you this. So lubricate it well, and then pack the nasal cavity. This will help in two things. One is it will help you to pack the nasal cavity easily, and the patient will have little pain when you're taking it out because of the liquid paraffin later. And similarly, these are the variants of intranasal packing, right? Different sort of materials that can be used. And this is Merosil. Okay, Merosil is it is a commercial product, so it is small in size, just like the size of the finger, or even smaller than this, and it is kept in the nasal cavity. And when inside the nasal cavity, it swells up, and it compresses the lateral wall, the medial wall, the roof, and the floor, and all the parts. And that way it will stop the bleeding. And similarly, the Simpson's balloon will compress the area of the bleeding area, and then the bleeding will stop. Okay, so see here, this is the ribbon gauze. It is 1 meter in length and 1 inch wide, and it has been lubricated. And you take the Tilly's forceps or bayonet forceps, and just you take it the end up to the here, okay, up to the inferior end of the posterior end of the inferior turbinate, right? This is the vestibular part, right? You are not supposed to pack only this part, right? Kati time ma chahi hamile ke bhन्छ भन्दाखेरि the patients have been यो area matra gauze piece हुन्छ, right? There is the gauze piece only in this area, and all this area is vacant, so that is not going to help. Right? So pack is in this way, layer by layer, so that there is enough compression. And in the end, this will become like this. Okay, the first piece was kept over here, and then the second piece, third piece, like this, like this, like this, like this, right? And all the areas packed so that there is compression of all the nasal cavity. Okay, here. How to do it? The ribbon gauze 1 meter long and 25 mm wide, something like 1 inch, and only 12 mm wide for children. It is done like this. Okay, I have already explained it. And the nasal cavity is packed in layers from the floor to roof, and the pack is removed only after 48 hours, but you can keep it for as long as 72 hours. That means after 2 to 3 days. And systemic antibiotics given to prevent sinus infection and toxic shock syndrome. Okay, this is what I meant by Merosil nasal tampon or Merosil pack. Okay, this is very commonly used, and it is very easy to use and very easy to take out. Okay, look at the size. This is very small, but when it goes inside the nasal cavity, it swells up and it compresses the area that we are interested in, and it will stop the bleeding. Now this Simpson's nasal balloon. Okay, this is a commercial product, and there are many other products like this. Nose-ma halyo, inflate garyo, it swells up and compresses, and the bleeding is stopped. Posterior epistaxis. Right? You have done the intranasal packing properly like this, right? But there is still bleeding, right? Then you need to suspect posterior epistaxis. But when the patient is bleeding, okay, you have done the interpacking, the patient is bleeding again. So you do not go for the posterior packing right away. do the anterior packing again. Repeat the anterior packing. Okay, but if the patient again bleeds after the second attempt of anterior packing, then go for posterior packing. So you can use a postnasal gauze, the fullest catheter, and other types of balloons. Okay, so you won't get these balloons here. Oh, hello. Good morning. म कल गर्छु है तपाईलाई अहिले क्लास लिँदैछु है 10-15 मिनेटमा. So you need to know about postnasal gauze pack and the fullest catheter. Right? And between these two, the fullest catheter is an easy method. Okay, so look here. So this is the gauze piece, and it has 3 ends. Right? So these 2 ends, they are coming from the nose, and 1 end is coming from the mouth, and the ends are pulled so that this part lies in the nasopharynx and compressing the odor plexus, any other bleeding that is present there, right? And along the posterior packing, you also need to do the anterior packing, right? So that means after you have done anterior and posterior nasal packing, anterior posterior nasal packing, so all the nasal cavity and the nasal pharynx will be packed, right? The patient will have to breathe in through the mouth, right? And this is the catheter introduction. So what you do is, right, a fullest catheter. So you have seen the fullest catheter, and we also have just inserted it in different patient, right? So you just put it inside nasal cavity, and here's the balloon, right? So you inflate the balloon and you pull it, right, towards the interior part of the nose. So that way, the posterior choana will be occluded, right? Okay, so the pack. So here the pack is pulled and it is fitted there in the nasopharynx. Right? So look here. Okay, so this is the gauze piece method. Okay, and look here. After this, the nasopharynx is packed, and the intranasal cavity has also been packed. Okay, in the layer by layer by layer by layer. Right. So you can do like this, but the easier method is just use the fullest catheter. Right? Fullest catheter. Inflate it as a balloon. Inflate it, and the posterior choana will be occluded. And along with posterior packing, do the intranasal packing. Right? So postnasal pack prepared by tying 3 gauze strips to each. 2 fullest catheter pass through the each nostrils, and their ends are brought out by mouth. Right? So here you get the idea, right? So the catheters, they are passed, and this end is suppose okay, this is the left side. Okay, so the end of the catheter is tied here, and it is pulled out here, and this is the right side, right? And it is pulled out here, and this is in the mouth, so that while taking it out, it should be pulled out through the mouth, and that way we just pack all of the nose, right? So this is how it is done. Okay, the third gauze piece is burned and taped to the tip, packed removed after 48 to 72 hours. Okay, after 2 or 3 days. Okay, so this is the method that is easier, and maybe you will be more likely doing this method. But using a gauze piece is a better idea. Okay, so this is a fullest catheter. You put it inside the nose, right, and inflate it and pull it back. Right? Pull it back, right? And then you also pack the intranasal cavity, right? And that way, right? And you put the pack like this, right? So before doing the posterior nasal packing, you should have attempted intranasal packing for 2 times at least. Usually intranasal packing will stop all sort of anterior bleeding, but it must be proper. Like these are other sorts of nasal balloons, right? You may not see this, so we just skip it, right? Okay, one of the ends, it goes into the nasopharynx, and another is in the nasal cavity. So that way, all the parts, the bleeding, the areas that have tendency to bleed, they are packed. So Epistaxis said, so whenever you are doing the intranasal packing, right? So you need to have all these things on standby, right? Gloves, gel foam, syringe, suction. This is a venous nasal speculum. This is a suction cannula, right? And this is the bayonet forceps, right? And these are the different commercial products. Right? Right? This is a mirror shield, right? This is some other sort of balloon, and like that. Surgical intervention for refractory epistaxis. So usually, and most of times, posterior and interior packing will control most of the bleeding, but sometimes they cannot get control. So in such cases, we need surgical intervention, right? So what we do here is we ligate the arteries. So in the first few slides, I showed you the branches of external carotid artery, right? So why? Because the source of the bleeding is from there, right? So the external carotid artery, ligate in the neck, distal to the superior thyroid artery. So you know that the first branch is the superior thyroid artery. So we do not ligate below the superior, just at the bifurcation of the internal carotid artery and the external carotid artery, because it has so many branches, and the thyroid artery, superior thyroid artery, the first branch, which doesn't have any role in epistaxis, right? And we don't want the blood supply to the thyroid to be cut off. Yeah? So we ligate it above the thyroid artery. But this is not the first modality. Even in arterial ligation, this comes at the last, or subicordium. Internal maxillary artery. Okay, so you know that internal maxillary artery is a very important artery. So we suspect that 90% of the bleeding is from the branches of the internal maxillary artery or the sphenoparietal artery. So kina त्यो 8 वटा artery kina ligate गर्ने हैन? Why to ligate the external carotid artery and stop the blood supply for all those 8 branches? So we try to only ligate the maxillary artery. Similarly, anterior and posterior small artery can be ligated. So just have an idea. So you could be asked this question because, so in a way like this. So you have an inter and posterior packing, but still the blood, bleeding doesn't stop. So what do you do? So you do arterial ligations. Okay. So look at this is the common carotid artery, and this is the external, and this is the internal carotid artery. So and here somewhere here you get the first branch, the superior thyroid artery. So you ligate around this area, and the blood supply is cut off. Okay, so this is the internal maxillary artery. Similarly, what we can do is angiography and embolization, submusical resection of septum, septodermoplasty, and endoscopic arterial clipping. So this is one surgery that you need to know well. So before we do the arterial ligation, we can attempt this endoscopic cautery and clipping. So what we can do is we can pass the nasal telescope and see inside the nasal cavity and try to locate the sphenoparietal artery, and using the cautery or the clips, so we ligate the sphenoparietal artery, and in most of the cases that will stop the bleeding. So this endoscopic ligation of the sphenoparietal artery is done before any other arterial ligation. This is also arterial ligation. So angiography and embolization, we need the help of interventional radiologist for this. Okay, this is not a very good clear diagram. We'll skip it. Okay, so that should be all.